Well, good morning, everyone. Mark Schmeler here again. I want to welcome you to day 2 of the International Seating Symposium. I have to say, I think yesterday went very well, and I'm looking forward to day number 2 here. A few housekeeping announcements that I'd like to make. People have been asking. We finally did a tally yesterday. We have 1,219 people attending the conference, representing almost or a little over 35 countries. So I want to thank you all again for supporting the ISS and being here. All of the recordings all of the sessions from yesterday have been recorded, as you know, and they are now uploaded and ready for viewing. The same will be for today's sessions and tomorrow's. We expect that should all be up and ready to go as soon as the ISS is over with. So again, if you're looking for something to do this week and weekend, you could go and binge watch all of the 100+ sessions that are out there and get CEUs for them. Another thing I'd like to draw attention to is the virtual exhibit hall. I really would encourage you to please take some time to go to the virtual exhibit hall. I did go there myself yesterday to a few of the exhibit halls and their exhibitors, and expect to do that again today. It's not difficult. If you go onto a page and you scroll down to their documents, click on links. You can go in and watch live product demonstrations. No one's necessarily going to bother you. I know I'm the kind of guy that likes to hang in the background and just watch. You can do that. If you want to be interactive, you can set up a meeting, you can do a chat. But I just wanted to say it's actually been a very positive experience, considering that we can't be in person. I thought it worked just as well as sometimes being there. The only difference is you can't necessarily touch the equipment, but there'll be opportunities to do that in other venues in the future. So I'd like you to please support our exhibitors and do that. For the other upcoming events today, last night we had some meet and greets. I thought those went very well also. There's going to be 3 this evening after the sessions are over with, starting at 5:45 Eastern time. This time it'll be the National Coalition of Assistive and Rehabilitation Technology, the Clinician Task Force, and the RESNA Group, Rehab Engineering and Assistive Technology Society of North America. And then tomorrow morning, early at 7 a.m. our time, will be the International Society of Wheelchair Professionals. Their link is right on their exhibitor page, and I believe we'll be sending that out also through push notifications today. So with that, today's morning plenary is going to be on large data, threats, and opportunity. We have a great panel of people put together here, and they will go and introduce themselves in a minute, but I just wanted to take a few minutes to talk about the topic because it is something that is close to me. We work with it every day as our team, and thought that now's the time to start talking about what this large data means, what are our opportunities, and what are the threats associated with it. So the first question always is what is large data? And that can have a lot of meanings, but basically it's recorded information, sets of variables, things about things that describe, what a situation is. Perhaps it might be an assessment tool. It might be something about a person. And it's also recording of a behavior or some kind of outcome or things that happen. Now you take this and you aggregate it into what we call large. And basically that can be voluminous, it can be countless, but at the same time, it should be consistent and it should have some uniformity to it so that you can look at things a certain way. Everybody's looking at the same variables, analyzing it so that we have some kind of consistent method of trying to explain or describe who we are and what we do. When you look at sources of data, we live in a society now where data is being collected. Sometimes we don't even know it's being collected. There's concerns about that in some situations, but for the most part, it's part of our society. It's being collected. Anytime we download an app or put software on our computer, if you read the fine print, I'm sure there's something in there saying, hey, by clicking this accept button, you agree to let us go and look at the information that you're transmitting through, whether it's your smartphone, your computer, or anywhere else. So social media is a perfect example of that. And obviously, social media companies are constantly tracking who we are and what we do, and they use that information for a lot of different purposes. The machines that are surrounding us right now also are collecting data, whether it's a satellite, whether it's something like a traffic light. They're looking at behaviors, they're looking at traffic flows, they're looking at people who are speeding, they're finding ways to send you tickets remotely for not complying with speed limits, but it's there, and municipalities use it all the time. The other course is like a transactional. Every time we purchase something, whether it's online, whether it's in a store, they're also collecting that data and they're using it for different purposes, trying to figure out who you are, what you're likely to buy, so that they can reach out to you in the future to provide more information about what they have to offer to you. Now, the strengths of large data is it does help with decision making. So there's some benefits here. We can look at trends in our organization of how our customers are reacting, or it might be the students in our university, or it could be any organization saying, before we make decisions on things, let's survey, let's look at trends, let's look at behaviors. Customer experience is important. Do people like us? Do they want to come back? What's the feedback we're getting? And what can we do to improve our processes so that we can keep the customers coming to us? So productivity is also a way to look at it. And then also putting things to market quickly. So feedback on products, for example, we can kind of like on demand almost look at what the feedback is through large data, and then adjust our practices or behaviors or manufacturing process as we need to. So obviously there's weaknesses to this. And so one is the quality of data. So the old garbage in, garbage out rule applies here. If we're collecting good data, we can make good decisions. If we're not collecting good data, we could be making decisions that aren't the best ones. And then obviously compliance with maintaining the data and so forth. Security, we've always had that question. It seems like there's consistently data breaches. We see them every day in the news. There's actually companies now that work around that. They protect us. So identity theft are all things that we have to be concerned about. And that goes into the weaknesses of the infrastructure that's managing all this large data. An opportunity, though, is we live in a data-driven world. If you look at policy, for example, laws are passed, Congress meets, assemblies meet, governments meet, and look at what is the trend of behavior? What is the trend of an existing law? Do we need to adjust that? We're making more informed decisions based on large data. And I also want to say, large data shouldn't replace common sense either. But what's nice is when data analytics reflect common sense and the two are working well together. So same thing with opportunities as far as manufacturing. We talked about, you could look at customer feedback, you can make adjustments to your processes, you can improve product based on what people are telling you. From a practitioner perspective, and say in healthcare, large data is being collected all the time. Now that we've gone pretty much to an electronic health record system, at least in most regions of the world, all of that data does get pulled. A lot of times it's de-identified. And again, we're looking at, what systems or what treatments or what wheelchairs work best for what people. And that kind of leads into where we are in the world of complex rehab and wheelchair seating and mobility, is we can, instrument our machines now and look at, how people are using them, what they're expected to last, when should we be replacing parts, for example. And I think that's an area that will definitely improve the credibility that we have. So again, going back to good policy making, policy should be based on science and evidence, and large data is something that can help to demonstrate that. So with large data too, it's an opportunity, I think, if you look at how we do research in our area, we've historically had limited research, limited evidence to show what we do, but being able to do studies in such a manner that are rigorous enough, the kind of like the randomized clinical trial, for example, doesn't really bode well to the type of work we do. So the alternative is, instead of doing nice, clean studies with control groups and all that, this is a way to more or less look at population data, or what I think of as census data, to see what devices work best for what people under what circumstances. When you look at threats to this whole thing, it's personal information. Are people willing to share their data? That's kind of a personal decision to make, but you can also see that, a lot of the apps that we see out there, there's always a section in the settings. It's like, donate your data. We're going to use it for these reasons. We're not going to identify you individually, but it's going to help us as we move forward to show what works and what doesn't work. The other threat to this is who owns this data. And, in a world of where we're trying to share data, there's data sharing agreements that have to be put in place in order to do that. And then at the end of the day is who maintains the ownership of it, and who puts the limits on what you can and cannot do with this data. And then the last threat I would talk about too is the knowledge. Data science, I think a data science statisticians, for example, are probably the most sought after individuals out there. And I think part of moving forward in the future now is really looking at and encouraging people to move into the world of data science, because we have a lot of data, but we probably have more data than we have people to analyze the data. So with that, I will turn it over to Laurie Watanabe, who's agreed to be the moderator of this panel today on large data threats and opportunities. So I'll go ahead, Laurie. Thank you for joining us today.
Thanks very much, Mark. Good morning, afternoon, good evening, wherever you are. We're very happy that you're here with us today, and thank you for joining us for this plenary on large data, threat, or opportunity. I'm Laurie Watanabe, the editor of Mobility Management Magazine, and it's my honor to moderate this panel. I'd like to start off by introducing our panelists, or rather have them introduce themselves very briefly, and we'll do this in alphabetical order because there's a few of us here this morning. So Theresa, can we start with you, please? Theresa, I think you're on mute. Okay, well, let's go to Karin, and we'll hope to pick up Theresa in just a second as she checks her controls. How's that? Karin, can you lead us off, please?
Absolutely. Well, good afternoon, everyone. I'm Karin Leire. I am based in Stockholm, Sweden. I am born and raised in life science. I have a Master of Biomedical Sciences, and I've been working with challenging standard of care through clinical research, regulatory strategies, and market access for very many years. And I started at Promobile 5 years ago, where I am the Vice President for Research and Innovation. And I continue that same mission of changing standard of care from this role, operating globally.
Okay, perfect. Thank you. Maria?
Thank you, Laurie. Can you hear me? Yes, thank you.
Yes, we can.
Thank you. Thank you. I would like to thank the organizing committee for inviting me to participate in this panel. My name is Maria Toro. I currently serve as Assistive Technology System Strengthening Global Advisor with Momentum Wheels for Humanity. This is an international NGO that currently is part of a large investment from the United States Agency for International Development that is working to strengthen the integration of rehabilitation and assistive technology into health systems. So my background is similar to Karin. I am a biomedical engineer and I have a PhD in rehab science from the University of Pittsburgh. Thank you. Over to you, Laurie.
Thank you. Gina, you're up next.
Everybody hear me? Good. Good morning, everyone. I'm Gina McKernan. I'm coming to you from the University of Pittsburgh, actually from my home office, because I have 3 children and I couldn't make it in time with dropping everybody off at school and daycare. And it's so great to see so many women represented here. That makes me really happy. I am a data scientist. I have a PhD in statistics, but have worked in both the private and public sector. I am a full-time faculty researcher at the University of Pittsburgh, have done a lot of big data claims and EHR mining, and just really found my passion in academia and using my skills and experience to improve the quality of life for people with disabilities. So it's an amazing experience. I have a dual appointment with the VA and in our human engineering research labs where we actually make assistive technology for people with disabilities. So really happy to be here. There's no chance of me leaving academia. The money's not great, but my heart's in it. So, and it's a great environment for me and for my family. So I'm again, I feel so lucky that I was asked to speak, and yeah, looking forward to this discussion.
Thanks, Gina. Jeannie.
Good morning, everyone, and thank you to the organizers of ISS, and huge compliments for what a day one technological miracle that got pulled off. So congrats. I'm a Caucasian woman with unfortunately really gray hair at this point in my career, but my mother told me it looked distinguished early on. So I'm going with distinguished. Physical therapist. I've been in the world of seating and wheeled mobility for many years, starting with working with children, and currently support adults with physical disabilities in New York City to live as independently as possible. I work directly with an organization called Independence Care System, and we run a wheelchair clinic called On a Roll. That is a community-based wheelchair clinic for largely a Medicaid population. And in both of those roles, senior vice president at ICS and running the clinic, we use relatively big data. More importantly, we try and use consistent data, both to manage our clinical practice and, more importantly, facilitate health and independence and mobility for our consumers.
Okay, thank you. Kyle, you're up next.
Yeah, thanks, Laurie. I also want to thank the ISS committee for having me a part of this panel. Really excited to be here and honored to be a part of all these other distinguished panelists as well. So my name is Kyle Walker. I currently serve as the Vice President of Rehabilitation Product Development for HomeLink. In my current capacity, I get to work with many stakeholders up and downstream, from providers to payers in our managed care organization, on the post-acute care side, really along the rehab spectrum, engage in different products to enhance and develop services for the end user. So thanks, Laurie.
Thanks, Kyle. And we're going to go back to Theresa now. Good morning, Theresa. Still not. Okay, so we'll work on getting Theresa's sound back on. And while we're doing that, I did want to give a little housekeeping item to everyone who's attending, who's watching us live. We'll be doing a Q&A segment at the end of this session. But you can send in your questions at any time, so feel free to do that. We're going to do a Q&A session at the very end. You could just type your questions into the chat window, and we will get to as many questions as we can fit into our plenary this morning. So now what we're going to do is we're going to start with our questions. So first of all, what I'd like to do is ask a question. I'm going to ask a particular panelist to get started with first comments, and then I'll open it up to the rest of the panel. So question number one, what does data do and what can it do for your organization? And Maria, I'd like to start with you, please. What can data do for us? What can it do for our organizations?
Thank you, Laurie. I was just checking whether Theresa was going to be able to introduce herself.
Can you hear me now? Just for
Yes.
Oh,
We can. Yay. Thank you, Theresa.
sorry. Go ahead. You want me to introduce myself?
Mm-hmm.
Sure.
Oh, okay. I even, just for the record, I checked in early and something.
You did. I know.
So thanks for your patience and thanks for allowing me to be on. I was worried that I wouldn't be able to be on the island of these great people. But I work at the Ohio State University Medical Center. And what I want to share is that we're in a clinic full time. I have my whole team with me virtually today. And a lot of what I speak about is going to be representative of all of them. So we have a full-time clinic and we gather data on all of our patients. And we really, I'll share later, but the data in the seating community has really helped us be a leader within our organization. So not only impacting our patients, but giving us recognition within the medical center, which is a big deal because we're a little small piece of the whole medical center. I've been in the industry for a really long time and grown up seeing the changes, and I'm just really excited to share what I have today. So thanks.
Thank you, Theresa. And just to repeat the question that I'll throw to Maria first, what does data do and what can it do for your organization? Maria?
Thank you, Laurie. Yeah, so I wanted to say thanks to Mark for setting the scene. So we all start talking about like the same definition about what data and large data is in the context of our conversation today. You might have remembered from my introduction that I do not work in the United States. So my experience that I'm gonna share today might be something different to what you're used to, because I know that the majority of the people here today with us is working in the US. So like what Mark said, like in one sentence and from my experience, data provide us with actionable insights. But we saw from Mark's presentation that there are many things related to data, the people that collected, what the data that we are collecting, the quality around that, the infrastructure. So really to be able to use the data for data to exist, many things need to come before actually having the data. So that's where my reflection comes today in terms of what data do. What can data do? It's really like taking a step back before the data. So in the context where I work and in many countries in the world, rehabilitation and assistive technology are not part of the medical system. So many of you of our panel speakers talked about and are gonna talk about their experience of AT services through healthcare systems. So you are part of a system that already exists. So when rehab and AT are not part of that system or a system at all, it is difficult to have that conversation around collecting data and even thinking about large data, because rehab and AT are not yet in the agenda of access to healthcare, for example. And even in countries that have made strides, for example, in health electronic records, if AT is not part of the medical system, like you cannot leverage that opportunity from electronic health records, and even thinking about the opportunity to gather large data sets. So then to the second question, in terms of my organization, what data can do for my organization. We work in the international development context. So we partner with different stakeholders, including governments, to plan for programs and implementation of activities around strengthening access to assistive technology. So for us, when data is available, when good quality data is available, we can approach our work together in terms of how do we make informed programming, right? Or evidence-based thinking about what we are going to do to continue to advance the change. And I love what Theresa said, that you have been seeing the change for many years, because that's very hopeful, right? Like we're working here very hard and we hope to see the change. So just to summarize, like data can do many things, but getting to the data, it's a very complex journey. So over to you, Laurie. Thank you.
That's really interesting that we know that data can be helpful, but getting to it is part of the journey. And then I guess implementing it and using it properly. Does anyone of our other panelists have any comments on that? If not, we can move on to my next question, which will be for Theresa.
I was just going to jump in and say that I agree completely, Maria, and also, you know, data serves as validation. As clinicians, you know, you might think or see that something's really beneficial, and but how do we prove that? How do we prove that to insurance companies? How do we prove that to providers? So having data to back things up is really evidence, and you know, it can be really powerful. And I have a colleague who's going to present later on something we were able to do with data that is going to, you know, change policy potentially.
Well, thank you, Gina. That's a perfect lead into my next question, which I'm going to direct to Theresa. And that's how do you use data in your organization if you're using it currently? How do you use it? What part of how does it become part, or what part does it play in your everyday operations? Is it a huge part of what you do every day? Theresa, I'd like to start with you, please.
Yeah, thank you. So we use the functional mobility assessment, which is a patient-reported outcome tool. And there's two things that it does for us. The first is it really helps us to monitor people over time. So, early in my career, we saw someone for the eval, we saw them 4 years later for their new chair. And that can't happen anymore. We have to see them throughout their kind of use of the chair. So we've implemented follow-up appointments that a lot of people come to, but some people don't. But what the data helps us do is catch those people when we have a patient-reported outcome that has decreased. So if they've decreased from their initial satisfaction, then it triggers us to reach out. It's amazing how many people that they just didn't call the vendor or call us. And I ask them, like, they'll stop using the equipment or they'll have problems with the equipment. It's like, why didn't you call us? Well, I don't know. And it's really taught me about the type of patients that we serve. Some of them just don't have that capacity to know who to call, where to call, when to call it. And by having that data that triggers a variation or deviation from where they were at, it allows us a safety net to go in and help them. The second thing it does is it helps us with program eval. So again, being an assistive technology center, small piece of a large medical center, the data allows us to reflect, well, what is our service? What is our eval to delivery? How are we doing compared to ourselves quarter to quarter and compared to the region nation? It helps us look at the patient satisfaction. Have we made a difference with our patients? How is what we're doing impacting their ability with their comfort, safety, their access? It also helps us with the recruitment as far as being able to advocate and showcase data. As Mark said earlier, we're in a data-driven society and people are like, well, why should I come there? Why should I come to OSU with the parking, the big city, to come to receive your services? We can prove to them what they're going to get if they invest the time. And then the larger thing that I keep going back to is that it really validates to leadership the impact that we have with our patients. And I know we're going to talk about policy, but when I go and ask for expenses or I ask for FTEs and I can show the impact and the value we have to the organization, that has allowed us to grow and get resources. So ultimately, it's about the patient and it's looking at their satisfaction with the equipment, but there's all these accessory benefits that the data can bring to us.
Okay, thank you, Theresa. Does anyone have anything they'd like to add?
I'd just like to add one thing, much like Theresa running a clinic, we found collecting reliable data and reporting back to staff on processes, for example. We've put in place a dashboard and we use a program called Tableau, which is very visual, and everybody can see where are we in terms of the number of people that were scheduled, how many cancellations have we had, what becomes the bottleneck in trying to get sufficient people through the door. And we've changed our practices. We send out text reminders. We, in the days of COVID, double booking people, not the greatest public health practice in the world. So we looked at our data and had to figure out different ways. But it's readily accessible. It's available to everybody in our program. And Tableau in particular, when we first rolled it out to our staff, I just loved one of my staff person says, I can now tell my kids why they need to graph the same information different ways. Everybody looked at the information a little differently, but somebody could see where their work was. And that made all the difference in everybody understanding why we were tracking something and that their actions were visible and helpful for all of us to reach the goal.
Thank you, Jeannie and
Laurie,
Theresa.
I might add something
Sure.
just to piggyback off what Theresa said. I think, Theresa, you said something along the lines of the justification of value. And, from my perspective in a managed care organization, how important that is to that stakeholder, whether it's an insurance payer or a provider, and then that correlation to that intervention. I think that's so important. I just wanted to say that's a great comment I believe you made.
Thanks.
Thanks, Kyle. My next question, I would like to start with Karin, please. The question is, what is currently working well in terms of identifying and or collecting data? Karin, can you start us off, please?
I'd love to. I think, I want to start off by looking at the large data sets and see that large data sets, they are convincing and they can't be neglected. And to the point where Mark started off saying data analytics reflect common sense. And I think what we all jointly in this room and all of you in the audience know that what we are talking about is common sense, but the greater world and the decision makers that we are to convince, they don't know common sense. They are our threat by having a lack of knowledge. And we have an opportunity by using large data sets wisely to prove to them and to allow for a health economical conversation in regards to assistive technology and why access to the correct assistive technology is so critical. And I think my best example of today where it works very well is those various connected devices that we are starting to get within complex rehab technology, where we can look at both product performance and on user behaviors, and to analyze that because the collection of data must be easy. And if it's done by hand, if say so, it must be included into an activity that you do anyway, since we always have a time constraint in practice, so to say. And at its best, it's done automatically. And when we look at the connected devices, we have that automatic capture of data, which either was there or is calculated on the device, so that we, with the help of this data, can empower the user. That's the most critical part from my perspective, that we can empower the user with a direct use of the data, and then the larger data sets are used for the analytics. So if we take the connected wheelchair as an example, where we today have 10,000 of our chairs are connected around the world, where the real-time information on how the chair is performing, the battery health, their sitting metrics, everything is fed to the user and empower them with the knowledge of their device, and they can then share choose to share it with say the service technician, and have, to your point, Theresa, have the remote access to understand the wheelchair and understand why it hasn't been used for the last weeks, because there was actually an error on it, for example. So that's again the best example, where the data is first instantly used, empower the user, and then is used for our advocacy when gathered in larger data sets.
I love that point, Karin, that information can be used in different ways. That data can be used in different ways, but one of the ways can be to immediately empower that user, immediately give them feedback, immediately, so that they see that data immediately helping them, right, and impacting their lives right away. It's not a mystery so much as it is kind of an everyday, a resource for them. Does anyone else have anything to add on that? No? All right, then I'm going to now turn that question around, and on the flip side of that, what do you think are the weaknesses in identifying or collecting data? And for that question, Gina, I'd like to start with you, please.
Well, there's a lot, I can tell you. I work with, primary and secondary data. So primary data, meaning data you're collecting from patients directly. Secondary data are things that you're obtaining through medical records or claims, or even, publicly available data that you're looking at, providing some information regarding a patient's location by means of their zip code or census tract. And, there's so many possibilities to enrich and add to your data set. The challenges, I think Mark, gave us some insight on this earlier this morning, is like the garbage in, garbage out. So the validity or the interpretation of your results are only going to be as good as the data that goes into it. And there's so many steps involved in, data integrity and quality and cleaning and even things like, we talk about ethical use of data, but we're starting to talk more about the ethical collection of data. So meaning, how is your data representative of the entire population of wheelchair users, for example? We know that some people self-select into research, into studies, and are we discriminating against people who don't have internet use or technology access, or don't get for PIT, an example would be like, don't get the PIT Plus Me study emails, so we do recognize that there are just inherent challenges in data collection due to its representativeness. So that's a big thing that I think we're starting to pay attention to as researchers. The NIH is really interested in this. It's definitely not a new thing, but we were focusing so much on the ethical use of data, but now really it's are we ethical in our collection of data? The process of ensuring data quality is long. So when we talk about actionable items and wanting things quickly, that's a real challenge. And the data analysis part, that statistical modeling, that's really the easy part. That's the part that is fun and it takes the least amount of time, but getting the data to that place is really is what takes so long. There's so many considerations. There's so many considerations for missing data. How is data missing? Why is it missing? Is it missing at random? Is it missing completely at random? Is it missing not at random? That's a whole course several courses in biostatistics, and it's really hard and complicated stuff. There are so many different things to consider, like when you're looking at data, there's intention to treat. Are we going to include everybody, even if they have missed visits or missed appointments? I see all of this on a daily basis, and it's always a struggle to get things done quickly, but also to do things accurately without errors. And the larger the data set, the easier it is to make errors, because you're still you have to there's so many more records to account for. And I think another challenge I see is that with technology and software and the availability and accessibility of it, it can get into the wrong hands. So people can use programs to run analyses. Maybe they don't have the right training to do it. And what if that happens? What if it gets into the wrong hands? And some of these computer programs will let you do things even though it's wrong. That's why I think I still have a job, and humans are still smarter than machines, right? Because I can tell that program that's an ordinal variable, not a continuous variable, but maybe the program thinks it's a continuous variable, not an ordinal variable. And I'm kind of alluding to a paper that my colleague will be presenting later in the session, but there's, you need experts. And I love that Mark had talked about, how important it is to have a trained expert in data on your team. And there's definitely not a lot of us. There's definitely not a lot of us in academia, because it's my colleagues are working at Google and startups and everything, but it's such valuable work that again, you have to get the right person in there to do it, and somebody who's gonna pay attention to the data and really understand it. And one more challenge too I think for the data analysts is we're not all content experts. I'm not a clinician, so it took me, I had to think about, some of, when you guys use acronyms about FMA scores, and, now I'm really familiar with it, but there's always that jargon too with data and clear, operationally defined variables. And you can call, a visit one thing in one data set and something else in another. So I could speak for hours about the challenges in data collection, but I do think that it's provided us with so much more, evidence and validation, despite all of the challenges and all the work that's involved.
Thanks, Gina. It's interesting to hear that you said, for instance, the more data you have, I mean, that can be a good thing, but it can also make the situation much more complex. And I think sometimes I've always thought of more data is just better. You want as much as you can get. But if you said as you said, if it doesn't represent everybody, for instance, because I think of seniors like my parents who may not self-select to give feedback, for instance, then if they get left out and that, that segment gets left out, then all of a sudden what you have is not representing everyone necessarily. So thank you, Gina. Does anyone else on the panel have anything to add about what the weaknesses are?
Lots of
hands go
Let
up.
me add one thing too, because we're talking
Okay.
about large data. I just want to remind people that when you have large data, it's really easy to detect statistical significance because of the amount of data that you have. So you should always think about effect size estimates and clinical significance and practical significance, because it's really easy to detect statistical significance. That's all I have to say. I mean, I have a lot to say, but I'll let everybody else talk too.
Okay, I'm going to go to Karin next. I think did you have your hand up, Karin?
Yes, and I'll make it quick. First comment goes back to where Maria started. We have a history among youth. I'm not a therapist, so I can say you therapists, you work with your hands. That's where your expertise is at in very many cases, and very much is handwritten. One weakness is that we don't, as Maria said, don't have the medical records set up well enough to do a proper documentation of what you've actually done, so that you then can, in a better way, go back in retrospective studies and see differences. So that's the one thing. The other thing is that we, as researchers in this field, we must get better at collaborating across which outcome measures that we use, so that we can be better at meta-analysis, and also to emphasize use of outcome measures that are really great. So that's a shout out.
Thank you. I'm going to go to Theresa next, and then we'll go to Jeannie.
Great. Thanks, Gina. That was really good. And when I listen to you talk, I think of, on my side, I have Carmen de Jovene that kind of does that big picture, the big data. And what I wanted to just mention is to the clinicians out there that don't get intimidated if you don't have this big data set, because it has to start someplace. And with us, we just started our workflow. What is your workflow? What is the capacities of your system? We know that collecting patient-reported outcomes is extra work, and we know that you're already collecting a lot of information. A seating therapist is challenged because they have their clinical documentation, their wheelchair documentation, their vendor documentation, at least in the US. And then we're saying, oh, now do patient-reported outcomes. So my suggestion for collecting data is to use your team, use the expertise that you have. I often go to my team to ask for suggestions on what would make it easier for them. And then I take it back, and Carmen and I figure out how we can implement it. And then I think also look at your workflow. It doesn't have to be huge and complicated, and you have to start someplace. And so we started very simple with hand tabulating it, and we grew, and now we have over 2,000 data sets that we can now analyze, but that didn't happen overnight. So don't get intimidated, and know that you can start someplace, but use the capacities of the system you have available.
Thank you, Theresa. Jeannie.
two things. One, a direct follow-up to Theresa, the comment I had made regarding current weaknesses is, have we really defined what we want to monitor? So you have to have your question in order to really make effective use of the data. And it also helps you, if you're not getting the information you thought you were going to, what's getting in your way? You have to go back and kind of fix that, back to Theresa's point of, and Gina and Karin, you know, if it's not easy to collect, it's not going to be, and then it's a lost opportunity. The one other thing, and Gina, you brought it up, of, you know, having a trained data analyst on your team. My comment on the other side was, we need more clinical experts trained in data analysis. We need that cross-fertilization and really helping clinicians not be intimidated by data, and analysts welcomed into our world, so that we can cross-fertilize and start coming with questions that result in data that results in changes of practice and policy.
Okay, thank you, Jeannie. And guess what? You're also the first up on the next question. So my question for you to get started on is, what are some opportunities for data to influence policy in addressing those weaknesses and priorities that we just talked about?
So I want to broaden the question slightly, in that
Sure.
I really feel like we also should be asking, how can data influence practice as well as policy? And one of my real big goals is to have data influence practice, and then practice influence policy. As particularly in the States, we have way too much policy influencing practice, not based on any data at all. And one big piece of advice to all of the folks listening in, get curious. I grew up, my mother said, curiosity kills the cat. Well, in fact, it doesn't kill the cat, but it makes for a much more informed cat. So I'm encouraging you all to become informed cats. And, you know, let's look at some data sources that maybe you haven't explored in terms of your practice, that can then lead to changes in policy. And I want to share with you just a recent experience that I had here locally in New York. And Kyle, it relates back to that, the demonstrating value to the managed care organizations, but ultimately meeting the needs of the end users who are wheelchair riders. We suddenly had a very large change in our denial letters coming from a particular provider. And rather than getting all hot under the collar that these people don't understand what we do, in fact, they didn't understand, but by going and analyzing the reasons for the denials, several things came out. The quality of our person-centered letters of medical necessity got much better. We were much more specific about why this person needed that particular product. We also unearthed something that I just want to share. New York State Medicaid had what we call a model contract with 19 different managed care organizations in New York City. And that model contract had a clause that said the managed care company was responsible for durable medical equipment in the home. That was the model contract. New York State Medicaid policy requires coverage of mobility devices in the home and or community. So within the state policy, there was this conflict. And of course, the managed care organizations had opted to the more restrictive, oh, we're only responsible for in the home. Well, by using our denial letters, our appeal processes, and partnering with the people who are the end users, so our folks with lived experience, they're the ones that went back to the Department of Health and said, there's a restrictive policy going on here. And here is the evidence of the restrictive policy. And they went back 3 or 4 times. They were not put off by the bureaucrats saying, Well, the policy is, to Karen's point, not all sense is common. And they were saying, well, it's really obvious that it's mobilities for use in the home and or community. And the end users came back and said, then why are we getting denials because something is needed in the community? So we were able to get New York State Department of Health to put in print and send out to all of their managed care companies that the requirement is for coverage in the home and or the community. But what was the data source? The data source was denial letters. It was the reasons that people were getting denials. And it took a long time to sift through, but the outcome was a real policy change that I encourage other folks not to look at a denial as I did something wrong, or this is a pain in the neck, or I don't have time to follow up on this. These are actually the ways that we can make policy changes. I won't use up more time.
Thank you, Jeannie. Does anyone else on the panel have anything to add to that? Maria.
Just a sad comment that you can actually make a large data set out of denials.
Isn't that true?
But it's holding people accountable for decisions that sometimes are absolutely capricious and arbitrary, but because it comes from the payer, and unless we fight back, we're not going to make a change in the policy.
Maria, I'm sorry, did you have your hand up?
Yes, I just wanted to add another opportunity that it's currently going on. So this is also like a high level opportunity. So the World Health Organization just recently published a new population-based survey that it's intended to capture the need for assistive technology in a context, and both the met and unmet need for AT. So in contexts where data is still very limited, and for advocates and people to build the case for investment for assistive technology, like this is a large data set approach that of course needs a lot of investment to be able to be implemented, but it is providing governments, like both at the regional and national level, it's providing them with quantitative information about that met and unmet need for AT, not only for sitting and mobility, but like for other assistive technologies. I'm gonna share the information in the chat so Rachel can share it with you. Thank you.
Thank you. Okay, next question. How can we leverage data analytics to produce significant impact on our stakeholders' goals? Kyle, can you start us off time, please?
Yes, Laurie, I'd be happy to. I think we've got to start with, as we identify those stakeholder goals and leverage that data, to ask ourselves, depend upon who's involved, a few questions. One of which we've got to identify who that stakeholder is. Is it a consumer of AT? Is it a provider of services? Is it a manufacturer of assistive technology, or is it an insurance company, managed care organization, policymaker? So identifying first who that stakeholder is. This stuff is not rocket science, but it's good to talk kind of through that process. The second piece of that is, I believe, identifying what those goals are. Let's use some examples here. From a consumer standpoint, potentially that consumer has had a history of chronic ulcers, and are they trying to mitigate their pressure profile? Right, so we can use data, maybe some of Permobil's virtual seating coach for some of that data. That's valuable, right, for that provider, or excuse me, from the consumer standpoint. Perhaps from the medical provider, maybe they're trying to get into a new market and they need to identify the top referral sources in that area. That's valuable, right, identifying that goal. Let's look at it from an insurer standpoint, and from a financial business perspective, potentially costs, right? We know that falls are very, very costly, and maybe that carrier is trying to reduce their expenditures around that. So that could be a goal of theirs. perhaps even from the assistive technology manufacturer. We'll use Permobil since Karin's here with us today. They're trying to develop a new product and bring it to market. They need data, right, to see if there's an appetite in this market, whether it's in a particular country or area of the United States, right? Or if that area of that market's already saturated. That's valuable. Then I think as we collect that data, we've got to ask ourselves a few questions, a lot of questions here, right? So one, is there a defined ROI? Is it a political policy ROI that we're looking for? Is there a clinical ROI? Or is that financial? And that's okay too. Understanding at the end of the day, as Gina, you had talked about, and we've said multiple people here, it's about the end user. It's that patient in the communities who's using these AT devices, right? The second thing here within that, the third component is it real world applicable? Is it meaningful? At the end of the day, gathering data is great, and I don't want to undermine any of that, and it's so valuable, but let's look at the applicability of that data. What's it going to do for that end user? What's it going to do for a policy? How's it going to make our world better? Laurie, you wrote an article just recently in December about relationships and meaningfulness recently in light of the public health emergency and COVID-19 and this world turmoil that many of us have never seen before. And ensuring that that data is meaningful is so important, okay? The next thing I want to comment on is, I think, Theresa, you had made a comment earlier about starting someplace. And when we look at some emerging opportunities for data collection and the analysis of that data, is there value to, maybe it's not as developed as maybe the FMA or even within your practice, but is there data to, or excuse me, is there value to collecting that data and just seeing it right now before we put some predictive modeling around it and policy implementation? Just collecting and seeing it, my opinion is yes, absolutely. I've been privileged to be a part of some conversations, even in the prosthetics and orthotics world, where they're talking about outcomes and analyzing some data through different resources. And it's very young and emerging. And is that okay? You bet. That is so valuable, because at time, when that end sample size continues to grow, you can then do that analysis and look at those predictive modeling opportunities to potentially impact best practice, right? So I think that's valuable. So when I come back, Laurie, to your question, you know, and how we leverage that data for stakeholder impact, we got to collect the data first and foremost. Secondly, run the analysis, run the modeling. Okay. Third, now I'm going to put my sales shoes on for a second, is you have to strike when the iron's hot and make that data and your value proposition meaningful to that decision maker. I can't emphasize that enough. I'm going to use a US based analogy here. So when you look at the LCDs, paint the picture, make it meaningful, make it real world applicable to that decision maker. At the end of the day, I think we all agree that numbers don't lie. You know, if there's the compliance piece of it, if there's that data integrity, you can't argue the numbers, guys. But I will, the other dichotomy, the other piece of that is, you got to make it meaningful to whoever is making that decision to write that policy, to make that financial implication, that change, or to the end user, what's meaningful in their life. The data is so empowering. But again, what Theresa said, start collecting it, and then it'll come with time, and then you can do the analysis and then the stakeholder engagement from there, Laurie. So.
Thanks, Kyle. That was great. Does anyone else on the panel have anything to add to that? Okay, then we will go into our last official question before we head into the Q&A portion, and we have been getting questions. So this is the last one I'll ask officially. Are there data related questions that you and your team currently can't answer, but that you wish you could? And Theresa, can you please be first up on this one?
Sure, it's a perfect follow-up to what Kyle said, because, you know, what I was thinking of with this is, you know, you want to make sure it's meaningful. You want to make sure that the people collecting it are receiving the input from it. Otherwise, they're not going to be invested. And luckily, we've achieved that. And so now we have all this data. And the dangerous question is, now we want to drill down. we not only want to know the patient-reported outcome, but I want to be able to, and so do my team, what does that mean for Matt or for Wendy? So being able to drill down to clinician-specific information on what is the eval to delivery so that I can look at efficiencies across our team and maybe opportunities. Looking at the patient, are there certain diagnoses that have not done well with certain products that maybe our decision should have been different? So as we do that long-term follow-up, should I maybe, if the information coming back is saying a scooter wasn't the best piece of equipment, or group 2 wasn't the best, or group 3 isn't being used, being able to really drill down further once you have that data to be able to give the team that information for kind of the return on their investment for collecting that information. Does that make sense?
It does.
Okay.
Does anyone else on the panel have anything to add or anything to follow up on?
I just have
Nope.
a
Oh.
very US centric
Okay.
in that Maria's absolutely right. Many of our connections where the seating and wheel mobility is through the healthcare industry, and for better or for worse, one of the larger valued outcome measures in healthcare is whether you've had an effect on the frequency of hospitalization and or frequency of emergency room use. And yet the payer of the hospitalization and the payer of the emergency room may not be sharing the data with the payer of the assistive technology. And so something that we could absolutely link and show our value because of lack of access, because the program wasn't built to share and to be able to share in a way that would demonstrate efficacy. So it's a definite US healthcare problem, but it's one that I think we should look for and point out opportunities where when a system of care has said, this is how I'm going to identify your value, but you don't have any way of influencing or documenting that you've made an impact in that same metric. You just have to call it out. You're being held to a standard that you can't measure against.
Okay, thank you, Jeannie. Maria, did you have your hand up?
Yes, I just wanted to add from a concrete experience in Colombia. So in Colombia, wheelchairs, you can access them through kind of the health insurance. And we know from the experience from users and from clinicians that most of the time the wheelchairs are denied by the system and then they are approved through court. And there's data, you know, because there's claim data, the data exists. And we want to answer the question in terms of the expenditure of the wheelchairs through the system. And we have been trying for many years to access the data and we haven't. And I think to the points that Gina and also Kyle mentioned before, like even if we get access to the data, then we still need the data scientists to work with us to be able to answer that question. So yeah, in this case, the data is there, but we haven't been able to access it. And we think we can answer a very powerful question that can potentially influence policy, but we're not there yet. Thank you.
Yeah, that's incredible. That's another layer to the question when you have the data but can't access it. It's obviously a very multi-layered question. Does anyone else on the panel have anything to add about what you wish the data could do for us? Because, oh, Karin, go ahead.
No, I'm dreaming at night about having a clear documentation in medical records about all secondary complications that our users are experiencing, so that we clearly through data could show how we, with the complex rehab technology, can prevent secondary complications. That would be fantastic.
You know, I may chime in, Laurie, if you don't mind.
Sure.
Piggyback off what Gina and Karin had said. And I think Dr. Schmeler had mentioned this yesterday in his discussion on FMA is, and I don't want to steal anybody's thunder, and Gina, if you have anything from Pitt specifically, but you know, I think when we look at the the chassis that the U.S. healthcare system is built upon, still primarily fee for service, I think that inherently causes some conflict. And if we can continue to transition to more accountable care organizations, value-based pay for performance models, where that data is part of that, I'm going to say compliance, but whole process, and bringing it full circle. Again, at the end of the day, for the end user, that's the goal. But if that's part of the expectation and the analysis and the sharing of data collectively, it's the opportunities and benefits are bidirectional. It benefits the end user, it benefits the insurer or payer of those services by mitigating expenditures, because you can do some predictive modeling and show that if you can give this type of equipment, it's going to reduce these expenditures. And at the end of the day, the patient's going to have better care, more access, and then they're going to have reduced expenditures. But I think it takes a concentrated team effort of stakeholders like the folks on this discussion panel to continue to advocate. And I know there's a lot of great individuals in our industry continue to push for those type of things.
Okay, thank you, Kyle. Anyone else? Are we good with this one? Okay. Thank you so much. What we're going to do now is open up to questions from the audience. Just to remind attendees, we're going to get to as many questions as we can. Please just type your question into the chat window, and let's get started with this. And if you're just any of the panelists, just let me know if you'd like to chime in on this. How do you avoid poor clinical decisions from influencing the data? For example, a novice clinician with no education or support making recommendations versus a seasoned ATP SMS with 30 years of experience may likely make very different decisions on the equipment. So do you have any advice or any comments on how to prevent sort of poor clinical decisions being made, or having those clinical decisions influence the resulting data?
Well, I'll speak up as a clinician who's mentored folks along the way. And the question actually brings me to a lot what Kendra was talking yesterday about a just culture. And if your data is indicating that a person, seasoned or not seasoned, a new person in the field is having difficulty with the clinical reasoning and perhaps isn't coming out with the outcomes from a end user perspective that you and your program would like to be sure that you're doing on a routine basis, that becomes a teaching opportunity. And that's part of why you look at data on a regular basis. So I really hesitate to say you would exclude that for some reason. If you're really interested in the long-term goal of better outcomes, we call it fault analysis. You learn way more from your mistakes than you learn when everything's going along really well. So I'd encourage people, collect that data, embrace it with a just culture, look for mistakes as a learning opportunity. Whether we do it in quality management all the time. You look for where the performance isn't where you want it to be, and that becomes a chance to teach somebody. Go ahead, Theresa.
Yeah, and I had to kind of process the question initially because, the data is a tool. It's one tool. So if you're a therapist by yourself and you don't know what you're doing is different, you have that data set that you can compare to. If you're a clinician within a team and there's mentoring and exactly what Jeannie said, it's that opportunity. But outside of the seating and positioning, patient-reported outcomes, a big deal. I mean, we're using this. I think the seating industry, assistive technology, we're coming up on it. We all need to start using the data as a tool and as that feedback. And the clinician, if you're not trying to compare yourself to see what your outcomes are, then we need to go back to the basics and not necessarily worry about that person blurring the data, but worrying about how we can collaborate together and improve upon it and educate and teach everybody how to use it and help each other with the tools and the workflow, because it is doable. And I don't want anyone to get discouraged if they don't have a system like I have or what Gina talks about. It really is doable, and it's powerful.
I wonder, Theresa, without knowing your processes at OSU, but do you use any of that data to differentiate or evaluate your clinicians for those patient-reported outcomes? Say, who are the best, and can we bring some of the others along and see what they're doing that the others may be missing a few things? Do you do that at all?
So the ability to drill down in a short term, I do not have that, but that's our goal. And I need to be able to get back to the data analysts, to the Ginas of the world, to say, here's what I want, here's what the information can teach me, because that's the ultimate goal in this health system where everybody's using patient-reported outcomes to be able, surgeons want it, knee replacement, joint replacements. They want to know if a therapist is influencing their surgical recovery.
Sure.
So we don't right now, but that is our goal, and we can infer some of it if I do some chart and audits.
Another note I'd make is, as an industry, I feel passionate that a clinician needs to be involved in the assessment process. And we use Theresa's method of you do a clinical assessment and establish a treatment plan, and then establish a AT order with the supplier. I think this is a place where we can compare what are the patient-reported outcomes when there's a team, a CRT supplier with a clinician, versus when somebody kind of goes it alone. I have real concerns that it could be viewed as not valuable to have both parties in the same place at the same time, when my deepest philosophy hypothesis is it absolutely is critical. But that's a place where, as an industry, I would love us to start collecting that level of data so we can demonstrate the value of the team, not a single provider being able to cover the whole landscape of a seating and mobility assessment.
Okay. Oh, Maria.
Yeah, I just wanted to provide a different perspective to that question, because we're talking about like the data after the service, but what about like the service itself, right? And Gina and Theresa, you talk about your team that you have and you're able to mentor people, but we have many settings where we have that provider is the first one and they don't have that support system. So what do we do? And then I think there's another question for data from that end that we didn't talk about today in terms of what artificial intelligence is going to be able to do to support new providers in places where they don't have mentors. And for that, I think Rachel is going to share in the chat box an opportunity for all of you that are very experienced clinicians to provide your information. It's for free to support the development of an artificial intelligence program that the World Health Organization is developing. Thank you.
Maria, I was thinking the same thing. The therapists that are in a rural setting, we want to support you. And we have this virtual platform. We have, a lot of forums. We have Resna. We want to support those therapists that are by themselves. So if you are one of those people, reach out and we're your safety net.
Yeah, I just quickly wanted to butt in here and say something, because that was a good question about, I think sometimes people are afraid to do outcomes because of, we don't want to know kind of thing, and it may be used against us. And I want to just reassure that that's not the purpose of this. If your scores are low, if your outcomes are not what they should be, that actually should be there to help you, to show leadership that you need resources. I'll use the example when we started using the functional independence measure in the late 80s. I worked in a very small rehab hospital in a very rural state. And our corporate leaders said our scores were the lowest compared to the rest of the hospitals in the region. But to show that we were less resourced, let's say, didn't have what we needed to serve a much more complex population of people, that got us more resources. And I could say the same thing here. If your scores are low, that's not necessarily a bad thing, but that's demonstrating that maybe there's additional training needing, maybe it's additional resources that you need. But we all say we need more things, but sometimes this data can work in your favor. Yes, there's always concerns. At the end of the day, your outcome measures are your independent variable. So whether you're doing a good job or a bad job, it's going to show up there. And if you need resources, it should be demonstrated through what your scores are showing. So I just want to say, don't run away from it because you're concerned about what your grades might be.
That's a really good point. Thanks, Mark. Okay, anyone else, or else we'll move to the next question. Okay, next question's a big one. How can clinicians and suppliers better collaborate to collect data? Any thoughts on that one? Clinicians and suppliers. Yeah.
I'll start. I think the first thing is clinicians and suppliers should always be on the same page about the mission and vision of what you're doing to support each other, so that if it comes up in a conversation, that the supplier can redirect them back to the clinician and vice versa. I don't know if there's specifics, like we shouldn't duplicate each other's work. So if we are doing some data collection we don't want the supplier to, because we don't want the consumer to be over surveyed. But I think that philosophically, the more we can collaborate and be on the same page, so when the variations come up in those follow-ups, we can kind of ping each other in helping with the solutions.
Okay.
The other thing I would say is start by sitting down with each other, without a client waiting for the next appointment. Really set a time. One of my favorite sayings is begin with the end in mind. So if we all want collection of this kind of data, and I'll give you another example, we were really concerned about repair times. And so we sat down with the supplier, the payor, the clinicians, and we established what it was that we were going to monitor. And we were able to map out, and we were able to identify where were the real bottlenecks, ultimately for the benefit of the person that was waiting for their chair to get fixed. So first thing would be to set some time, establish the question, determine what you're going to collect, and then figure out who can do that in the most efficient way. And Theresa's point of not over surveying people, we have a handoff with our suppliers, so we'll collect the initial data and the delivery data, and then we'll ask the supplier to do follow-up at 2, 3, 4 months later. And again, if you have a decrease in the score, or somebody's giving you a comment that warrants a feedback, let's be sure that they're coming back. So one, be thoughtful and set up what it is you're collecting, who's collecting it, and most importantly, go back and look at the data.
Okay, thank you, Jeannie. Does anyone else have any input? Oh, we're good. Okay, Theresa, I had a question. Specifically, I think you were talking about the need to follow up and how often you're in contact with the consumer. So the question was, I think, just for clarification, do you follow up on all wheelchair deliveries yearly? Are you following up on certain ones like Group 3 Power and ultra lightweights, or do you do it for everybody?
Great question. And this is something that we've developed over time also. Initially with the Group 3 Power Chair, the therapist will do a 1-month follow-up to see how the operation and how things are running with the equipment. And then from that point, depending on the need, they may then do a 6-month. So the variation between the delivery and the 1 year is driven by the patient needs and the complexity. However, there could be a more simple chair that the consumer doesn't feel comfortable using, that we may do some follow-up with a Group 2. We also do follow-up via telehealth. So we may do a follow-up to see how the equipment is doing in their home, since we're in the clinic. But then ultimately we have a 1-year follow-up with every patient. And they're scheduled with the physician and with us to check in so that we can document the continued use of the chair. And then obviously if there's any variations, we're always available to see them. That answer your question?
I think so.
Okay.
Yep. And Theresa, sorry, another one about that survey. Did you create your own survey for the clinic? Do you think a survey could help to identify potential questions, such as identifying patient satisfaction, but also addressing comfort, safety, accessibility, or if the equipment has been abandoned?
So the primary patient reported outcome we use is the FMA, Functional Mobility Assessment. We also have a patient satisfaction through like the hospital medical center about just their satisfaction with the services. And then the therapist individually will use like the WUSB or some specific impairment focused patient reported outcomes that we don't have as much longitudinal information unless we have that patient that is coming back. Then within the medical chart, we can compare like the wheelchair skills, the WUSB. My colleague Wendy yesterday with the surgery, she has specific impairment focused patient reported outcomes that she will track. But those aren't really the large data set. It's going to be more for the individual consumer.
Okay, perfect. Next question. Some wheelchairs now have phone chips in them for update and location. Is this technology being used to gather information on the use of the equipment, such as distance traveled, number of times the seat functions are utilized, etc.?
I can respond to that question. At Promobile, all the powered wheelchairs leaving our factories today have a Connect Me module in them. It's important to clarify that submission of data is deactivated until you as user personally activate it. So there's no data transfer until you've allowed for that. But as you say, yes, when you have activated it, it starts showing you in your app how far you traveled, how much you use your power function, the health of your battery, how far you can go on your remaining battery capacity, etc. And also enables for remote service on the device, since your service technician can see the data on your chair if you choose to share it. Yes.
Okay, great. I have
Can
a
I make a-
follow-up. Oh,
Laurie,
go
can I
ahead,
make a
Kyle.
comment to that?
Sure.
This is my own perspective and opinion, and I'm going to state a fear of mine. And if anybody would like to comment, please, I'm open to that. Is there potential for a payer policy to implement a compliance piece of that based upon utilization, power functions as part of the payment model and the patient to receive services? That's a fear of mine, to be honest with you. If that data would be used in that capacity. I don't know if anybody has any thoughts, comments, but I don't know.
So basically, Kyle, you're saying that maybe if a payer gets a hold of data that says that certain consumers aren't using their tilt and recline for pressure relief, and that's how you got them qualified, for instance, was they needed the pressure relief and needed help with that, and then the
Correct.
payer finds out that they're not using it as their clinician wants them to, could that potentially backfire and be used to take it away, or maybe as a bigger policy to say, well, we're really reluctant maybe to fund those because we've seen that some people don't use it? Is that what, am I getting that
Yes,
right?
and yeah, you're right. And the other dichotomy is, would that also, and I say this very loosely, but incentivize the end user to actually use that then to their benefit? I think it could potentially go both ways, but my fear is, you're right, Laurie, on the other end. So.
And I think the important thing to know here is that we have the data on how that chair has been used, but we know nothing about the user. And that's the important thing here, that you can't draw those conclusions unless you also have information about the user in place. Because if you are, what should I say? If you are hospitalized, you of course don't use your chair for 2 weeks. That doesn't mean that you shouldn't have have access to your wheelchair anymore. And there are so many variables in this, and that's why we really take privacy seriously. And to make the connection to the presentation that closed ISS last time, when Sharon Sonnenblum said, well, I reached out to the manufacturers, but I didn't get, they wouldn't give me any data. So what are they doing with the data? And that's kind of, that's the thing we really take seriously. We don't give any data sets out for someone to on their own and make those, do those calculations to maybe see if we have trends that go in a direction that's against the compliance that we're expected to see. We are, however, very positive to collaborate with researchers where you're in the informed consent state, that we will also, as a component in this study, we will also include all the data from the chair, so we know exactly how it's been used, and then we can make the direct connections between what they show in their outcomes and how they've actually used the wheelchair, and that gives an extra component to what we've never had before in research on wheelchair users, that we can actually see that they use that function on the wheelchair that we are evaluating in the study. We know exactly how much they have been standing and how frequently they did it and for how long time. And that's very important if we are evaluating the benefit of a powered wheelchair with a standing function, for example. So yes, Kyle, I agree with your fear. We hear it often, and I think we need to be able to turn this around in the same way as you do with, if you see in pharmaceuticals, when you talk compliance, it's like, if you don't take your medication, we need to do something about it. Sure. And that's the same thing here. If we see that the user isn't tilting and reclining as much as you as a therapist have told them to, when you jointly look on their data in their app, or if they choose to share it with you, then you need to do something about that. Then there's a reason for them not using it. But that comes back to the training that you mentioned, Jean, and how there's then a reason for them not doing it properly, which then requires an intervention.
One last thing that I'll add, and Kyle, thanks so much for bringing up the concern. I want to insert practice back in there too, because we have a fair amount of practice that is the best of our information to date. If actual data shows us that someone doesn't have to tilt back 45 degrees and they still maintain skin integrity, that's really important information. And I take this full cycle. What if somebody is changing their seat position 15 degrees, but they do it 5 or 6 times in an hour? An actuator that only goes back 15 degrees, I bet, is a lot less expensive to produce than an actuator that holds a 300-pound person at a 45-degree angle. So I want people to be upfront on both sides. Is data telling us that the outcome might be different than what we hypothesized? And what does that mean in terms of our practice? And then how can our practice inform policy and product? So even though it may be different than what you think, that's, again, the learning opportunity.
I just want to add one thing as the statistician here of the group, sure. And kind of doing myself a disservice, but just to remind everyone that, all statistical models are wrong. Some are useful. And that was said by this famous British English statistician years and years ago. So we use them to help make decisions, but, we're not at the point of personalized medicine or artificial intelligence where they're taking the place of an interaction. So, I love my job so much, but, I always like to remind people of that too, that they're used as tools, and everything is used as an ancillary support, but they don't ever take the place of you know, when you're in there with a patient and you have a feeling of what's best for them. And we can create algorithms and decision trees and everything, but at the end of the day, it's, you know, it all goes back to that that interaction. And I'll continue to create predictive models and statistical models to help you make decisions, but you know, we got to be reminded of that as well.
Perfect. Anyone else want a last word on this? Nope. Well, thank you so much. Thank you to all our panelists. Thank you for all the attendees for being here for our discussion on large data and its very many possibilities. I'm going to announce the CEU code for this session. So if you need that, grab a pen real quick and write this down. The code for this session is 0NKJEM. That's 0NKJEM. A reminder to any attendees who are viewing this session on demand after the fact, you'll also need to complete a post-plenary quiz as part of the CEU process. So to everyone here with us live today, thank you so much for joining us for this plenary. A reminder that the first instructional sessions of today start at 10:15 a.m. Eastern Time. Thank you so much for your time. Have a great rest of your day.
Thank you. Thanks, panel. Thanks, Laurie,
Thank
for
you
the
so
great
much.
questions.
Thank you.
It was a pleasure being on.